Okay, let's move to the second part and let's go through the several aspects here just to name them. So the first question, how to avoid mortality, lung damage and other sequels. The other one is maybe to elaborate on just what you mentioned about intubation, how to protect oneself, how to protect the medical personnel from infection. We may go back to early treatment, um, how to proceed with early treatment, the question of telemedicine. Young people, usually it's considered a elderly people issue, but young people also are susceptible to develop this disease, of course. What about the elderly? And the need for potential more information research. So that's what we are going to go through. And maybe first, if you can comment about how to avoid mortality, what can we do to avoid mortality? We are all susceptible. And how to avoid lung damage and damage to other organs. And
that's actually one of my patients. That actually is a 32-year-old African American man that worked in a hospital, but he worked in a cafeteria of the hospital serving people. He presented to us with shortness of breath, and what you can see depicted in this image is that the right lung, the lower part of the right lung, is gone. By gone, I mean it's completely covered by the inflammatory response that COVID gives you. So this is a person that is very sick. In his case, he only had one area of the lung that was bad. We avoided to intubate him. We avoided to put a tube on him because we knew, like I told you, if we put the tube in, that would get him in trouble. Now, this is extremely important that we discuss because you were mentioning earlier elderly people. In our experience and what we have seen in the United States is that the young people are the ones that are getting the infection the most. I have tested over 40,000 people for coronavirus doing a drive-through testing. 40,000, I know it sounds like a big number, but it's not even close to what we really need. Of them, the vast majority of people, 80% of people are people of color. African Americans, Hispanics, Asians, 80%. And what gets you most is that most of the ones that get it, especially the ones that get it bad, are young African American and young Hispanic males. So I know that, in Europe and in China, a lot of the people that got into trouble were those who were over the age of 65 and things like that. But in the United States of America, we're not seeing that. We're actually seeing that the young people are the ones that are getting in trouble, and we cannot explain why.
Okay. So this concept of avoiding intubation as much as possible, if you see that slide regarding recovery deterioration, maybe you can comment on that about how the general scheme for respiratory support.
Well, the first thing that you need to understand is that, like I said, we manage these patients differently. Whereas in some other instances, I would not allow somebody's oxygen to be kind of low, and I get very aggressive and I intubate them. When I have a patient with COVID, I do what is known as accepting permissive hypoxemia. That means I accept that the patient is going to have a little low oxygen without being low enough to get him into strokes or stuff like that. So I will do whatever I can to keep him at an oxygen level that is safe. But for that, I will titrate the amount of oxygen that I give them based on the low number that I want. I don't want to keep them at 100% for oxygen. If they have an oxygen of 85, I'm very happy. I give them what is known as high flow nasal oxygens, contrary to your normal little oxygen cannula that you use, where you can give 2 to 6 liters of oxygen. I actually put them on a special oxygen cannula that can give up to 60 liters per minute. So I do that. We have seen that patients that are laying back on their backs tend to have low oxygen. So what we do is we flip them like a pancake and then put them on their abdomen, on their belly, and their oxygenation improves. So we try to keep them on their on their abdomen as long as they can tolerate it, as much time as we can. We try, like I said, to avoid intubation because once we get the patient intubated, our concern is that the ventilator does more harm than good. So you know how at the beginning of this pandemic, there were governors looking for ventilators because they didn't have enough ventilators, and we were using the same mentality, the same critical care mentality that we have used for the last 40 years, which is put tubes, put tubes, put tubes. But now that we are recognizing that putting a tube is actually something bad, we'll do whatever we have to prevent that. Now, if the patient requires a ventilator, we use very specific ventilator settings, if you want to call them like that, specific pressure values that we're trying to do to keep the patient from having more damage to their lungs related to the ventilator.
And all of these protocol is something that has been developed collectively with Professor Marik and others. That's
correct. We have a group of people, Dr. Umberto Meduri, who is a big mechanical ventilator person and an expert in cortisone and cortisone-like periods. We have Dr. Jose Iglesias. We have Dr. Pierre Curry, myself. I mean, we started as a group of 5 clinicians with the same goal in mind, which was let's go ahead and treat the issues that are being caused by the coronavirus in a manner that is a little different than what we do on a day-to-day basis. Let's focus on treating the inflammation and then see if we can stop the cascade of events somehow, instead of just supporting the person with, with ventilators and ECMO machines and things like that.
What about, there is a picture of you. Maybe you can explain about how, your outfit and the picture of you, but how do you protect yourself? How do you protect the medical personnel in your hospital?
I mean, we are very picky as to how we do it. We don't, I mean, we know that we're dealing with highly infective patients. We know that, like I told you, we learn every day something about this virus, and there's many unknowns. So we try to protect ourselves as much as we want. In the picture that you have depicted, you see me wearing a protective equipment. And actually, the way it happens is kind of fascinating. I get to the hospital, I take off my regular clothes, and I get some special disposable scrubs, like these ones, but disposable. Then on top of that, I get the PPE, the white one that you see depicted there. On top of that, I put in the other blue gown. And then, I use 2 N95s. I'm very picky. I don't go for 1, I go for 2, because every N95 I have tested has some leak somewhere. So I do 2 N95s. I have goggles. In addition, I have a special shield on top of me. Now, the reason why I have a picture of myself on top of the gown is because once you are a patient and you enter one of these COVID units, most people are going to come in and looking like they're in a spacesuit. And you don't know who's treating you. I mean, it's the most scary thing that can happen to a human being. So trying to humanize a little bit what's going on, I came up with the idea of, hey, why don't I just put a picture of me outside? And it's a lot of people have followed this crazy thing all over the world. And it's kind of funny when I put a picture of Brad Pitt inside to see a patient, and they just laugh, because they know that we're having fun. But you want them to have some things. Most of actually in my unit, everybody, whether it's a medical student, whether it is the cleaning lady, everybody comes in with a picture so that people can identify with them.
So who is on the picture with you?
In this picture, I have one of my nurses. Her name is Jerusha. She's been working with us since the beginning of opening our COVID unit. And
so you are able to keep yourself and the staff safe at this point in terms of?
As of today, since March, we have not had a single member of our staff that had gotten coronavirus from the work environment. I mean, I knock on wood that will continue to be the case, but we've had instances where we have CPR, where we have emergencies, where we have to do things like that that they are virus generating procedures. We try. I mean, we really try. Is it 100% safe? No, it's not. That's why what we do is, that's why, you know, so many people are reluctant to see patients in the COVID unit.